bottle of wine. If I've been out till 2:45, would you lock the door? Will you still need me? Will you still feed me when I'm 64?
And now the podcast where together we discuss proactive aging on your terms, connecting to the professional advice of our special guests while creating better days throughout the aging process. Now here's your host, Mark Turnbull.
And welcome back to another lively discussion on aging today. We are the podcast where together we explore the many options to aging on your terms. You can find Aging Today and our past programs on our website. We got a great website. All you got to do is go to www.agingtoday.us and you can pick up any of the past programs. There's about 400 of them. It's amazing that there's that much topic out there, but aging is incredible. We're all aging. And then I always say that if you're not too busy being born, you're too busy aging. But you can also follow us on your favorite podcast channel, such as Spotify, Pandora, Apple, iHeart, YouTube. We've got about 15 of them out there. So do feel free to type in Aging Today, follow us, and you can pick up any of the past programs. And then also, I'm so grateful for you, the listener, all 200,000 plus of you that are following us on your favorite podcast and Aging Today. And I just want to say thank you, and from the bottom of my heart, because without you, this isn't even possible. And we want to know what your questions are. So keep asking the questions. Send to me in an email your questions, and then also if you have an aging expert that you would like to hear on the Aging Today podcast, just reach out to me, your host, Mark Turnbull, and my email is mark with a K, mark@agingtoday.us. Well, as you know, this is about a podcast about the story of aging, and I've already said that if you're not too busy being born, you're too busy aging, and you know, think about that. There's nothing more to it than living on this planet and for how many years that we're living, and we're all aging at various levels. But one of the things that has always intrigued me about the body, the human body, is as we age and as we grow older, things change. And sometimes I don't like the changes that are going on in our bodies. And I have a lot of questions for why we're changing so dramatically. And one of the things that where we see a lot of change is in our bone structure. We see a lot of changes in our hormonal structure. I don't know if that's the right word, but I'm using it. And here to guide us today along this journey is Dr. Kristi Tough DeSapri, and she's going to be leading us in this discussion on osteoporosis, menopause, and other age-related sagging issues, if I may say so. Dr. DeSapri, welcome to Aging Today.
Hi, Mark. Happy to be here.
Yeah.
Well, you're right. We are all aging, but as I like to say, we can do that gracefully. We can do it with strength, and we can do it without fractures. So I think we're going to talk about all of those things: bone health, bone strength, falls, and prevention of fractures today.
Yeah, and I love that you are so optimistic about aging gracefully, because if you look at my smiling mug, it's not grace. There's nothing graceful about me. So, but maybe that's my own image issue, right? Okay, so let's get into it. And you know, maybe that aging gracefully is as we take care of our bodies. Is that when you say, when that's kind of, it's a loaded term, gracefully. So what does that mean to you?
Yeah, I mean, I think we all, particularly, so my area of interest is women's health. I'm a menopause specialist. I'm also a clinically certified densitometrist. I'm a board certified internist, and I have practiced in women's health after my fellowship at the Cleveland Clinic. So I have seen women, through the reproductive span, and then my focus really is on women after the reproductive years. And so what happens in the menopause transition and menopause years beyond. So when I say gracefully, I think of that as all the body systems, right? Looking at cardiovascular, looking at breast health, looking at bone health, primarily, and again, making sure that we're, individualizing treatment for women who come with certain past medical histories, and then want to look forward to, maintaining good health. And I think there's so much now in midlife women's health, a lot of technologies, a lot of medications, a lot of more awareness about those years beyond, childbearing. So that's sort of how I, see each woman as an individual, and then also think about what's going to, help her live well and live a long time without any of those medical issues we want to prevent.
Yeah, and there's solutions. And
Absolutely.
we're going to talk about those solutions today to aging gracefully, aging well, another way of saying it. And so let's get into it. The thing that holds us upright is the bones that we have in our body. It's the skeletal structure. Without that, we'd, I guess, be like jellyfish slithering across the floor, right? So the bones are extremely important. So
Absolutely. You're right.
Yeah.
Right. So go ahead.
I was going to say, what is osteoporosis? What is happening to us and our bones as we age?
Yeah. So you set the framework, no pun intended, really well with talking about the skeleton and, our bones. And so you're absolutely right. The skeleton is very important for mobility, for supporting our internal structures. We actually also have a lot of our main nutrients and vitamins, inside of our bones, like calcium and different phosphorus and different minerals and cells. And then, when we think about bones, we usually don't think about those until someone, has a fracture or is diagnosed with osteoporosis or has broken a bone or thinks about things like arthritis. And so we really don't think about, our bones until maybe, sometimes it's too late. So what is osteoporosis? This is probably one of the most common questions that I get. I see women, day in, day out in my clinical practice talking about osteoporosis, what it is and what it isn't. And really, osteoporosis means, osseous is a term for bone, and porosis, porous. So it means weakened or thinner bone mineral density, which means that your bone density is weaker, your bone strength is compromised, and that leads to an increased risk of a fracture. We call those low trauma fractures, so fractures from a standing height or less, or fractures from in our spine can even be from like a twist or a bend that's exaggerated. So, unfortunately for osteoporosis, this is a term and a sort of a condition that is silent. So many women don't know they have it unless they've had a screening DEXA, which we'll talk about, I'm sure, in terms of how we screen for osteoporosis. Or the more unfortunate is they've had a low trauma fracture, like a fracture of their wrist, forearm, spine, hip, pelvis, and that's really either changed their life. They're either had in a cast or they've been immobilized, or hip fractures really carry some more significant consequences. So osteoporosis is really the end. So of where we want to prevent. We want to prevent getting thinner bone density. We want to understand why we have that condition, and we obviously want to treat that. And we'll I hope get to talking about all those components today. Yeah,
I want to talk a little bit about the bones themselves and what makes up bone, what chemicals, what nutrients, And the reason why I ask that question is when we start out as children, our bones are a lot more pliable. And then as we age, whatever's happening in the aging process, they become more brittle, or in osteoporosis, the more, what was the term you used?
Thin or thinner. Mm-hmm.
So what's happening? I mean, we just not getting the right nutrients? And is it possible, maybe not today, but is it possible into the future that will they be able to find the solution that will keep bones pliable and healthy till you're 120?
Yeah, well, I think that there's definitely, there's a lot to that question, and you're right. So, bones are made up of many different cells. They are made of, like I mentioned, calcium, phosphorus, different types of bone cells that we call osteoblasts, or bone-forming cells, osteoclasts or bone breakdown cells. So we have something called osteocytes, where a sort of the nerve conductor of the cell. So we have all these sort of cells within our bones, and they all work together to what we call either do some modeling or bone formation, which primarily occurs in our teens, our 20s. And then depending on the skeletal site, like the wrist or the ribs or the clavicle, we know that you really sort of achieve peak bone mass in your 20s, which means you've really built up your bone bank, is how I describe it to my patients, of all the bone that you're going to have in your early 20s, maybe closer to your 30s, and then you sort of plateau. And primarily for women, we know that the time of menopause, whether that's surgical menopause or natural menopause, when we're starting to lose our primarily estrogen hormone secreted from the ovaries, that is where that imbalance of bone being formed by the osteoblasts and bone being broken down by the osteoclasts starts to go haywire. And we know that when there's a lot of drops in estrogen, again, around the time of menopause, which can be for many women, sometimes age 40 to 60, depending on when that final menstrual period is and when those hormones are changing, is that there is an imbalance of more bone breakdown than bone formation is happening. So, you're on the Aging Today podcast. I mean, we are all aging. The trick is, right, we want to trick our bones into building up more bone or stimulating what we call the osteoblasts, tricking our bones to reduce the osteoclasts, but also just allowing our own bone to remodel as it would, because all those cellular structures and those cellular processes are very important to maintain healthy bone in both the trabecular bone compartment, which is primarily bones in our spine and our femoral neck of our hip, and cortical bone, which is primarily densely packed bone in our long bones of our body, like our wrist, our femur, etc. So every bone in our body is made up of those two different components, slightly different cells, slightly different rates of remodeling and bone formation. But again, really important. And genetics plays such an important role. Exercise, calcium, like I mentioned, because that mineralizes the bone, all things play a really important role in how each one of us is different in terms of how much bone is being formed, or your bone bank, and how much bone is being broken down. And like I said, for women, so important to know what's happening at menopause and really building and boosting the bone bank as much as we can, and understanding your history as it relates to bone health, and how that's impacted before the time of menopause. And that's, I think, what we're talking about here today, really the pivotal time of menopause, where we need to understand, what our bone density is to prevent more fractures and prevent bone loss. So
is there a difference between men and women and their bone bank?
Absolutely. So, men obviously have generally, when we look at the curves for bone formation and bone breakdown, we know that men start with a higher bone mass, again, probably due to size, testosterone. Men also do have estrogen actually as well. So, we know that generally for most men, we know that the bone mineral acquisition is higher for men than women, and also that men do not have a menopause. Right? There's no time where men lose a dramatic amount of testosterone, where women can lose up to 20% of their bone mass in both the trabecular and cortical compartment at the time of menopause. We know from literature that women who are thinner, women who have family history of bone loss, can lose more bone density. So again, men don't have the menopause. We still can lose bone density in men, and it's still important to do screening bone mineral density in men of a certain age, primarily men over age 70, or men who have some chronic medical conditions that might contribute to bone loss or increased risk of fractures. So yes, we don't want to forget about the men.
Yeah. Well, and this is a relevant topic to today. I mean, we're questioning what is a woman. And what you're saying, is that there is a difference between the sexes. There is two sexes, and they're uniquely designed, and they have their own challenges, and it must be in the DNA, or there must be a lot of things that are going on there. Why we're so different? You would think. Why does there have to be a difference in the bone structure between a man and a woman when we're kind of both equal in the sense that we're walking this earth, why did there become a difference?
Right. And well, there is some interesting, research done in the gender affirming hormones and bone health that's ongoing and really in its infancy, but is gaining more traction because we are seeing this more often. And when we look at the large scale, 8 million women have osteoporosis that we know of. In the United States, about 2 million men. So again, some of the sex differences in terms of bone mass acquisition, menopause, certain, conditions, primarily things like autoimmune conditions can sometimes preferentially affect women. So those sometimes carry risks of needing things like glucocorticoids or steroids as their treatment. We know that there's such a large component of women now getting diagnosed with hereditary breast and ovarian cancer. And so a lot of those women who've undergone early surgical menopause, that can affect their bone mineral density as well. So really, again, age of menopause is very important for understanding, what our peak bone mass is and how to preserve it for those, menopausal years. As we know, women are living a third to sometimes a half of their lives in the postmenopausal years.
Yeah. Yeah, and we're only going to live longer, I believe. I mean, there's some amazing things that are happening out there with longevity, and we've already seen, the longevity of humankind working together and moving forward. It's not uncommon for us, I have an in-home care agency and a hospice agency, and it's not uncommon for us to be caring for people in their hundreds. And I don't know if that was really a prevalent thing maybe 40, 50 years ago.
Yeah, absolutely. On a personal note, I have a maternal grandmother who turned 100 this month, which is very exciting. So, I mean, again, anecdotally, but I agree with you. And the other thing with, aging, again, comes with, well, what are the consequences? And so one, interesting statistics is that, right, we are living longer, women are living longer, men are living longer. However, with osteoporosis, again, because of this silent condition, it's sort of projected that hip fractures will double by the year of 2050, which means, right, that if we're living longer and our bones need to, we need to, have our bones grow with us, the end consequences of thinning of the bone, as we talked about with osteoporosis, is fractures in women, primarily, again, and men too, who are in the 80th and 90th decades of life, tend to have the prevalence of hip fractures are higher than women in their 50s and 60s. And that's because, again, when we think about falls, 1 in 3 women fall over the age of 65 and males as well. And we know that is one of the main reasons, for emergency room visits is falls in the elderly. And so when we think about, prevention of osteoporosis, treatment of osteoporosis, the hip fracture is in our field, in the bone health field, likened to, a heart attack or, a cardiovascular event, meaning, we want to prevent things until we want to prevent your falls and your fractures before they occur, because those fractures are, again, the hip fracture is really a sentinel event. And really, again, when we look at the large scale literature, a third of people do not, walk or live independently again. We know that there's a high mortality rate after hip fractures, again, from the fracture itself and from the sequelae. So really, when I see women, and we know that looking at the hip bone mineral density is so pivotally important as we age, is really an indicator of what the bone strength is. We really want to prevent, all fractures, but, really the life-changing fractures for hip fractures in women and men who are of those demographics is really important.
Because we're all aging and we're all living longer as we age, what are some of the things that we can do to prevent the bones from, deteriorating? And is there things that we can, foods? Is there certain foods that are more that we should be introducing into our diets more to keep our bones more pliable and healthy as we age?
Mm-hmm. So this is such a common question, we get about lifestyle, which includes, again, exercise and then also nutrition. I think, where we are now in our world, we have so many options. So I spend a lot of time talking about the things that are, again, what I mentioned, what are the building blocks to bone. Mm-hmm. And so nutrients, but, essential minerals such as calcium are very important. We're so lucky, in this country, and I really think many countries that have calcium-rich foods or dairy sources or non-dairy sources of fortified foods with calcium. And there's, the recommended daily allowance really for again, postmenopausal women is really 12 to 1,500 milligrams of elemental calcium a day. And again, so getting that calcium, whether that can be through dietary sources or supplements, primarily, again, that's really an individualized discussion in terms of your history, making sure those are safe, they're not going to cause constipation and kidney stones, and looking at the total inventory of what you're already, doing. That's really important. We talk about vitamin D, which also helps absorb calcium, certain nutrients, primarily things like protein intake. We know so much more about that and how that is supporting muscle around the bone. So, there are a lot of observational studies looking at calcium and vitamin D, but we really know, again, those are building blocks. But what I always like to share is, and I'm very much into, counseling as the whole person, is that if you have osteoporosis and that's, again, sort of more, bone loss that is advanced to a point that, really calcium and vitamin D, and we know this from, placebo-controlled studies, calcium and vitamin D alone are not going to mineralize or fill in the bone mineral density that's lost. We really need to do something to boost those bone cells and really work on within the bone mechanics that I talked about, really to strengthen the bone that's either there or build up some new bone mass to really support that. And it's similar to a lot of our other chronic conditions where we sort of want to control the blood pressure and control the lipids and again make those levels look optimal, because we know those are the areas where optimal aging occurs in, and we don't have the signs of bone loss and fractures. So this is really, again, a discussion about treatments beyond calcium and vitamin D for women who again have advanced bone loss or osteoporosis.
Yeah, and there's really kind of two categories. It's the when we're younger, we should be making sure that we're taking enough vitamin D and calcium and all the other things that are going to build up that bone bank in us. And then there's when the bone bank is empty, it's dry, if you will. Then there's another process or another approach that you're taking. Is that what you're saying?
Yeah, exactly. I think, right, for each decade of life, it can be a little bit different, premenopausal versus postmenopausal. Again, we know that calcium, we should probably be talking about that in our, with our pediatricians and with our younger children too, things like that leach calcium out of the bones. We want to, avoid those, like excess, sodium or salt, excess, sodas, things like that, which can affect, that calcium balance. And then I think, again, it just becomes paying more attention. I think, as we age, we need to pay more attention to, the macronutrients than the micronutrients. And I think calcium is one of those ones that kind of sometimes gets overlooked or has a bad, rap. Some people say they're allergic to that, there's, of course, there's lactose intolerance, but there's a lot of other ways to get calcium for folks who identify like that. And I think sometimes it's just learning. I share a lot things like looking at certain websites like the Bone Health and Osteoporosis Foundation, which is a great nonprofit that really tries to educate both clinicians, healthcare providers, as well as patients on terms of understanding osteoporosis and, again, how to live with this diagnosis, how to prevent and treat the diagnosis as well.
Yeah, and I think we've had a lot of guests on, and we talk a lot about whole food, plant-based nutritions and different things, and so if you're not going to do a lot of dairy products, so you've got to find other ways to get the calcium and the vitamin D if you're not going to have dairy products, because it sounds like dairy products are the highest form. Am I correct, or the most convenient form to get calcium in our diets?
Yeah, absolutely. They're not fortified like some of the other products. However, you can, like from a lot of our non-fortified, our fortified milk products now, such examples like almond milk, coconut milk, soy milk, all of those can be fortified with calcium. And so sometimes those are good options. But there are so many out there. And so again, it's, what works in your diet? And then consistency is key, because we know that with low calcium or low vitamin D, again, you're not mineralizing your bone. And as we age, I said there was, more bone breakdown happening. Well, we need to replenish those stores. And so we need to make sure that the bone is mineralized. in addition to very common when I see patients, they think if they're on an osteoporosis treatment, either a medicine that prevents bone loss or one that stimulates bone formation, either oral or injectable, that they know they're now like off the hook for taking calcium, vitamin D, that's doing the trick. And that's something that, it's so important to know that no, you need to still take, even if you're taking a medication, great, but we still need the building blocks. So including calcium, vitamin D, again, some sort of exercise, resistance exercise, posture balance, all of those things.
Let's talk about the elephant in the room, menopause. And so how does menopause affect osteoporosis, and let's start off with what is menopause, and then how does what's the relationship between the two?
Sure. Yeah, I think this is really, menopause itself is really getting a little bit more media attention. I think we've got some celebrities talking about how, their menopause, journeys. I think that there's some more physicians and technology out there. But it's really important, that, menopause is a natural state. Okay. So this is really defined retrospectively. Menopause is a time period in women's life where they have undergone 12 months of no periods, or what we call amenorrhea. And sometimes that's, again, a look-back diagnosis. Some women have irregular cycles for many years up until their final menstrual period, and we call that time, the early or late perimenopause time before we enter sort of the menopause transition and then the final menstrual period. And then the years post-menopause would be after that. So, and again, if there's surgical menopause, that can be an abrupt cessation of period because, again, the ovaries are removed. Oftentimes I see women who have undergone, chemical menopause, so are either taking medications primarily for like hereditary breast and ovarian cancer or chemotherapy, radiation that really stops periods. And so, as I mentioned, in this country, the average age of menopause is 51 and a half, but there can be a long, span. We know, menopausal symptoms, such as, hot flashes, night sweats, and things like that don't just happen, in menopause. They can happen early in the perimenopause and really can continue for someone for 7 to 10 years. So hot flashes and vasomotor symptoms and night sweats and disturbed sleep, joint pains, and mood symptoms, insomnia, things like these can be more commonly related. There are some other uncommon, things that we hear about with menopause, like dryness of the skin or chest or palpitation. But the one we don't talk about often is bone loss, right? So no one comes to me and says, oh, I'm in menopause, like what's going on with my bones? They say, I'm in menopause, like what's going on with my joints hurt? I'm having vaginal dryness. I can't sleep at night. But again, when we know what's happening, underneath the skin, so to say, in the bones, we know that at the 12 months before the final menstrual period that estrogen's declining, the bone loss, particularly we know this from looking at bone markers and looking at bone density declines, that the bone has already started to decrease more. We see those changes in the spine, so in the trabecular bone. And so women come with their spinal bone mineral densities that can be lower than their hip, and they're confused. And that, again, is primarily because of the rate of remodeling that happens in the bone at the time of menopause. So that's why it's, again, really important, to know when you're going through menopause and then what your risk factors for bone loss might be. Because, at the time of menopause, if you have risk factors for bone loss, which are many, family history, genetics, medicine, surgery, etc., the bone mineral density, you need that assessed, right, with either a fracture risk assessment or a bone mineral density screen.
You're listening to Aging Today with your host, Mark Turnbull, and his guest, Dr. Kristi Tough DeSapri, and the understated topic in menopause, postmenopause, and osteoporosis. You can find out more at her website, boneandbodywh.com. We'll have more with Mark and Dr. DeSapri in just a moment.
Sometimes I'd like to smack old age right in the kisser. Ow!
Oh yeah, still got those moves.
I will be fabulous.
Comfort Care can help with as much or as little home care as you need. From medication reminders and meal prep to everyday chores and errands. Let us create your personalized care plan and find the perfect caregiver match so you can live your best life possible.
Call Comfort Care at 503-636-0417.
A Did You Know moment from Comfort Care Home Care of West Lynn. Did you know in the U.S., 6,000 women enter the menopause transition every day? That's more than 2 million per year. And 1 in 2 women over the age of 50 years will sustain an osteoporosis-related fracture, a broken bone, in her lifetime, which is more than 1 in 8 women who will be diagnosed with breast cancer. And finally, once a woman has sustained an osteoporosis-related fracture or broken bone, she has a 5 times higher risk of having another fracture in the following years. This Did You Know moment was provided by today's guest and is brought to you by Comfort Care Home Care. Call today at 503-636-0417.
And now more with Mark Turnbull and his guest, Dr. Kristi Tough DeSapri, in our discussion about menopause, postmenopause, and osteoporosis on Aging Today.
I was wondering if there was cause and effect. Does menopause cause osteoporosis, osteoporosis cause menopause, or is it individual and they're independent of each other? How closely related are they?
Well, I think, oftentimes we're only getting a bone mineral density assessment at the time of menopause, unless women have come for, the premenopausal years have had, bone loss due to either, anorexia, eating disorders, or they've had, a genetic predisposition. Maybe they've had a lot of stress fractures. So really, again, we know that there are many risk factors for osteoporosis, including, like I said, genetics and medical history. So certain things like diabetes, rheumatoid arthritis, celiac disease. I mean, so many that can affect the way that calcium is metabolized. Those, can contribute again to bone loss that we are not only picking up at the time of menopause, because for many of our medical societies, really the indication for a bone mineral density screening is the time after the final menstrual period. Until the age of 65, if you have risk factors for bone loss. So, age of menopause, being on the, lower body mass, surgical history medicines, particularly like things like steroids or breast cancer survivors on aromatase inhibitors, all of those things. So just because we pick it up at menopause, in the time of menopause, we know that bone loss is occurring before. And again, awareness is really like, why I'm working here today with Amgen on awareness about, when is bone mineral density, when do we need to think about that, and how do we need to think about that to, again, think about preventing those fractures in the future and maintaining bone mass.
Yeah. And when it comes to menopause, menopause, is it hormonal primarily? Is the body losing its hormones, and then that's what causes this transition in life?
Absolutely. Yep.
Okay. And
so loss of estrogen from the ovaries, we know testosterone also decreases, but that actually declines sort of more in a stepwise fashion, even starting in our 30s. And, again, we have estrogen receptors everywhere in our body. So all those symptoms that I just mentioned in terms of, sort of things like brain fog, joint pains, cardiovascular symptoms, those are all because we have estrogen receptors, both estrogen alpha and beta, in all of our body and all the cells of our body. So from our head, really, in the hypothalamus that affects hot flashes, to our toes and our joints, even in our feet and ankle.
Yeah. So we really need to take menopause seriously, because if we don't take it seriously, then it's going to have an increasing effect upon our bone structure.
Right. Absolutely. And it's one part, right? So I mentioned there's some women who come, again, most women come with symptoms of menopause, or I say they're the lucky few that get no symptoms, but we know 70-80% of women get some sort of symptoms of menopause, whether that's, the panoply of symptoms I mentioned, or just a few of those symptoms. But again, bone loss is that hidden, silent, symptom.
That's the hidden, silent one. Yeah.
Exactly.
So,
but even more important that we think about calcium, hormones at that time if they're indicated, because we know we're even leaching more calcium out of our bones at the time of menopause. So again, just to bring it back to the calcium being important at the time of menopause as well.
Yeah. And so there's a lot of talk about hormonal replacement therapies, and how important is that? Because And I say that, and I talked to my wife, Christina, and I said, it's okay if I talk a little bit about you because she's going through it as well, and she gave me permission. So one of the things, that she's not done anything. And I'm going, well, shouldn't you? And she says, well, the doctor said, don't do any replacement things until there's some problems or whatever. And I'm just sitting there going, well, that's not very proactive in my mind, but I don't know what I'm talking about.
Yeah.
So how do you approach that?
Yeah, well, I think, right. So if we're really thinking, about looking at bone sort of in isolation. So we're thinking about, again, the menopause transition, women in their 50s for natural menopause. Again, if we're talking about this demographic. So if you do have bone loss, which is the beginnings of bone loss, is called something like osteopenia. Now we refer to that as low bone mass, or osteoporosis. Hormone therapy, we actually call it hormone therapy, not hormone replacement therapy. So hormone therapy is really the correct term because, we're not replacing, all of the hormones that are lost at the time of menopause. We're giving back small fractions to offset bone loss and also treat symptoms, that are there. We're not trying to replicate a premenopausal state. So you're right. This is a very nuanced discussion. Again, also individualized. When we think about the medical societies, particularly, I'm very involved in the Menopause Society, and we look at the evidence for using hormone therapy. It really is for women who have symptoms of menopause, moderate to severe bothersome vasomotor symptoms, and those symptoms I mentioned. Treatment of 𝙤𝙤𝙤𝙤𝙤 syndrome of menopause, another great topic, maybe we can talk about on your show another time, which is vaginal dryness, painful intercourse, recurrent urinary tract infections, changes that happen, again, due to lack of estrogen in the vagina and the vulva and the lower 1/3 of the bladder. And then, again, and it's sort of like the third one is hormone therapy is indicated for the prevention of osteoporosis. It is no longer considered FDA approved for treatment of osteoporosis after the Women's Health Initiative study. However, when we look at women who are low absolute risk for fractures and who are less than age 60 and less than 10 years since menopause, there's some good evidence that hormone therapy also, prevents fractures. And so, and maintains the bone mass. And so this is where the discussion comes in with women who generally have a couple symptoms and they've had some bone loss. And if they have no absolute contraindications for hormone therapy, we do talk about that. Hormones actually, again, is in that class of preventing bone loss. We know that there are a lot of other ones, oral, injectables, and things, but this can be one of the options that we talk about, both that treats menopausal symptoms and helps, again, offset bone loss. And there's so many different ways hormone therapy comes. Bioidentical hormones is a marketing term, but they generally mean biosimilar hormones that are similar to what our own ovaries made in our reproductive years, that are given either orally or transdermally or per the vagina. And then there's also progestogens, which is the second part, which prevents the uterus lining from thickening, are very important if you have not undergone a hysterectomy. So again, I talk a lot every day about, what would be the indications, what's the contraindications, and then I think we are still in this sort of gray zone, or whether we're now recommending women for prevention, using hormone therapy for prevention of aging. And I don't recommend that, but I do think for women with symptoms or with signs that we see, things like bone loss, 𝙤𝙤𝙤𝙤𝙤 syndrome of menopause, really, again, we don't necessarily need to suffer through menopause anymore. And that's really the message that I think is so important from the healthcare community. And I hope also from, media and other things that are happening around the menopause discussion.
Yeah, I wanted to talk a little bit about, there's always two philosophies or two approaches to everything. And one is, the more natural approach versus, more of a, I don't know, for lack of a better word, and again, shows my ignorance, you can correct me on this, but more pharmaceutical approach to, addressing the whole menopause. Mm-hmm. Mm-hmm. What's your thoughts on that?
Yeah, and I would say it's the same with addressing osteoporosis. So, my thought is that, menopause is, like I mentioned, is a natural process. Osteoporosis or bone thinning, some of that is inevitable, with, again, looking at each woman as an individual or as men as well. But we can prevent the outcome of thinning of the bones, such as fractures. And so I think they're all important together. I mean, it's kind of like you ask a dentist, like, what's more important, brushing or flossing? I mean, it's kind of like, I use that analogy. I mean, it's like they're both important. Like, right? They ask you every time if you're doing both. So I think it's really important.
We always have those extremes. So we always want to compartmentalize and put people into camps. And I just go, well, maybe both. Can't you have both?
Right. Absolutely. So, right. So that is absolutely, as a trained physician, I'm really, within, within this field of bone health and menopause. It's around, again, I think I try and stay up to date on both and keep up with the research on both, because I learn from patients, oftentimes, or I review the small studies that are, brought in and sort of say, okay, yes, maybe, or, we don't have we don't have all the answers in medicine. But what I would say, when we think about, particularly when we think about osteoporosis, and like I said, women who say, I like to do this the natural route, I obviously always want to support things like calcium, vitamin D, exercise, balance training, reduction of falls. But again, we really need to support the natural structures that we already have. So the things like the osteoblast, we need to build, support that and boost that up. And we have medications that can do that. We have medicines that can work on reducing that bone turnover, so slowing that down so that your own body sort of naturally fills in its own bone. So again, I think it's sort of working within these are, a lot of these medications are working within the confines of what we already have within our bone and just stimulating. And so, I often recommend, many websites, which I mentioned, the Bone Health and Osteoporosis Foundation. There's another one that is understandop.com, which is, again, where there's some more information on, being proactive, how to start that conversation with a healthcare provider, again, trained in bone mineral density or trained in, there can be so many different clinicians that know about osteoporosis, whether that be rheumatologist, endocrinologist, primary care, gynecologist, so sports medicine. I mean, there's so many different takes on this. So really starting that conversation, if you have had bone loss or you are at risk for fractures, or really, sort of, educate yourself and hopefully, again, start that conversation.
Yeah, and it's not that you can reverse menopause, but you can slow it, the progression or the effects of it, by exercising and diet and, making sure that you're getting enough calcium and vitamin D, and on it goes, correct?
Yeah, for bone loss. I mean, when we think about, we live in the menopausal years, the estrogen deficiencies, again, are across our body. So we want to treat the symptoms. So, for women who have vasomotor symptoms, again, not just like toughing that out, really there's hormones, there's non-hormonal options, things like vaginal dryness. We have lots of, again, hormone estrogen-like options, non-hormonal options as well. And then for, bone loss, we do have things like we mentioned, that slow bone loss, or again, treat osteoporosis, because, again, once bone has been lost, more dramatically, we want to work within the confines to, reduce the risk of fractures. Because as I mentioned, I mean, I see so many women, for both things like, the prevention of the first fracture. And it's very hard because osteoporosis is not tangible. What does a wrist fracture look like? And I've seen patients, who are, we know that with wrist fractures, primarily that's happening in women in their 50s and 60s, and they might be at the peak of their career, and they're architects, and they're drawing, and they're, and they're trying to continue exercising. And we know that injuries really, can set people back. And then not to mention, like I talked about, the hip fracture and the sequelae of those things. So again, it's trying to treat, so we prevent the outcomes, primarily, again, fractures, because fractures as we age are becoming more common. We know that 1 in 2 women over the age of 50 will sustain an osteoporosis related fracture in her lifetime, and 1 in 4 men. So we have a lot of work to do. This is why things like this are very important. Creating awareness, in the media, creating awareness with Amgen is so important, because we need to get this message out so we do a better job at screening, diagnosing, and treating osteoporosis to make a shift in those numbers.
Yeah, and because I'm a guy and I want to fix things. Okay, so when my wife is going through, some of the symptoms, and I'm thinking of hot flashes and night sweats, I'm like, okay, what can I do to help? How can I fix this? And, she says, relax, you can't. Okay, but how then should the partners respond and to support someone that's going through menopause and that you found effective?
Yeah, so I always joke that I don't think I'm the first to say it, but it's sort of like putting the men back in the menopause, right? So, and it's very kind that you are and thoughtful that you are thinking about that. So, yeah, I mean, there are a lot of things I would primarily say that, if you're listening and there are a lot of good medical societies where you can find a trained, clinician. So there are, there's a society called the Menopause Society where you can find a physician or a clinician all throughout the United States. And there's even an international menopause society if you're listening and you're international. So that would be the first step, I would say, to find someone who is going to validate your symptoms and again, talk to you about the treatment options besides things like a cooling blanket and a fan and keeping your room 65 to 68 degrees. I mean, there are lifestyle things to do. You can always go, with your partner to the appointment as well. And sometimes, we underestimate things, and then our partners remind us how important they are. So I think that would be a good first step. I think there's some really great literature out there. There's some good podcasts. Again, I would stick with sort of the physician or medical community bent, which again are I think both, talk about all the things we've talked about: lifestyle, risk factors, and what to do. So, so good, some good information out there. More books are coming out, I feel like, every day.
Yeah.
Talking about this.
Knowledge is power. And the more knowledge that we have, it'll improve all of our lives.
Yeah, I think educate the knowledge and making sure that it's coming from an educated, source, primarily physician source. I think it's very important around this topic.
Yeah.
Especially right now.
And along with that, knowledge is power. There's a lot of knowledge out there that maybe isn't accurate or incorrect, and there's a lot of misconceptions. So what are some of those misconceptions that we can address?
Yeah, so I think a lot of the misconceptions, are around the fact that, osteoporosis is inevitable, fractures, height loss, is inevitable. But we know with, a lot of our therapies, like we've talked about here, you can reduce a risk of a fracture by 40 to 50%. So it's not that, we just need to sort of live with this, that, osteoporosis can be treated, can be prevented. The other thing that we forget is that, once one fracture occurs, sometimes, fractures are treated in places like the emergency room or, are sort of forgotten about. We sort of sustain a fracture and then move on. But what we're really appreciating now is that, if you've had one osteoporosis related fracture, you're 5 times more likely to have another fracture, and the risk of another fracture is highest between the first and 1 to 2 years after an initial fracture. So it's not like one and done. We know that once you've had a fracture, it tells us something about your bone mineral quality, your bone mineral density, your bone strength. Maybe you're falling. We need to address that. And so I think common misconception is, this is inevitable. This is just, aging. This is the natural progression, but it's not, and it doesn't go away, right? So finding someone to talk about, so I mentioned that website, understandop.com, but finding someone to talk about osteoporosis, to get your options for treatment, whether that's, again, the combination of lifestyle options, nutritional options, and then therapeutic options, putting exercise in there as well, is really, really important because I think there's, again, everyone thinks, fractures are just a sign of aging, but it really is, again, something that we can alter and we can affect in a positive way.
So you've mentioned that every woman will experience menopause at some point in their life. And so what are some things that women and men can do to prepare themselves for that day when menopause comes knocking at the door? And it's, you said it was around 51. Is there premenopausal? And we've talked a little bit about that. Things that you can eat and exercise and all that. But what are some specific things? And then as you're making that transition, there's all kinds of symptoms. And I know you've already spelled out a lot of those symptoms, but let's talk about some of those symptoms and then postmenopausal. So let's take right through the process.
Yeah. So, you're right. Perimenopause is also sort of this time where it's very nebulous. It can last anywhere. Some women start perimenopause in their early 30s. On average, we think perimenopause, is sort of starts in the late 40s, and that can be hallmarks of different things. So we know that menstrual cycle changes, particularly if have had sort of regular menstrual cycles, and you're not on a contraceptive. We know that menstrual cycle changes start to happen. Sometimes periods get lighter, heavier, get closer together. So things like, seeing women who have cycles within every 21 days. Some people then start to skip cycles. So have 1 month skipping, 2 months skipping. So skipping cycles. And then symptoms, right? Symptomatology. And it's very hard. A lot of women come and they want to know their estrogen level and they want to know certain levels. But we know that that's sort of a moving target in the perimenopause time. Very hard to, see where you're at. Or you're getting close to menopause or you're not getting close to menopause.
I didn't know that. I thought estrogen levels were one of the key. It's really. Like, checking your oil. You got a dipstick. And no, that has nothing to do with it.
No, yeah, it can be. And unfortunately, a lot of the laboratory companies now do think that that is the way. But really, if you're going to check estrogen level off contraceptives, it really has to be the third day after the first day, meaning your first, day of menstrual bleeding at the third day. But that's what we do in the reproductive, we check something called an estradiol and an FSH, but that really is more when women are trying to get pregnant, and we're looking at things like reproductive endocrinology and reproductive infertility. So it's very hard to be reliable is basically what I'm saying. So symptoms of menstrual cycle changes, things like perimenopausal symptoms can be things like if you've suffered from, mood symptoms before your cycles, that can be one. Sleeplessness, changes in, things like anxiety. Like I mentioned, some people have some palpitations. So again, these are all things that can be, perimenopause, and some women have them and some women don't. But it is important, I think, when you're going to your either annual gynecologist or annual, or internist. Hopefully, again, they're asking you about these symptoms. You're aware of these symptoms. For a lot of women in their 40s, they're still on contraceptives, and that is safe up until the time of menopause. Again, if we look at your, it's not just age that determines what sort of contraceptives we can use nowadays. We have to look at your, medical history, medicines, things like that. To determine what's safe. And so some women are on things like the oral contraceptives or a patch or the IUD, have had, different, procedures done. So again, we have to look at those things because those might impact your, having symptoms or not having symptoms. So sometimes we try and replace back some of the hormones. Mm-hmm. And then other times, again, it's, lifestyle things, making sure we're safely prescribing something. So I think, again, making sure you know your numbers, like you're knowing your cholesterol before you hit menopause. We know that, the weight changes, in 99% of women. We know that when at the time of menopause, so much is happening in terms of our changes in glucose metabolism, fat metabolism, that we become less metabolically active. So more of our muscle tissue sort of gets converted into adipose or fat tissue. So really trying to work on adding in resistance exercises, really trying to achieve an optimal, body weight, muscle mass. All those things are really important before menopause because naturally things will shift with that decline in estrogen. We know that this is very common. So really trying to get into, again, shape is different for every woman, but getting into I would say just like the best metabolic self that you can is really important. Making sure your cholesterol is normal, your diabetes screen is good, you're working on resistance exercises, and keeping body mass within the normal limits is very important because we know that things can change through the menopause transition.
Yeah. And who do we see? What kind of a doctor? Do we go to the primary physician to start with, and they refer us on, or do we? Is the primary skilled enough to go through this whole thing?
Yeah, so this is like where the field of menopause medicine is a little bit more is too small. We really need more women who are looking at midlife women through the lifespan. So a lot of women are seeing a gynecologist, so particularly if women have had children and then are moving on. So gynecologists, some internists. Again, the level of knowledge changes. I'm working a lot with different organizations, things like Ms. Medicine. Again, like working with the Menopause Society, other educational events or organizations to kind of improve the education for internists, gynecologists. And some have, good training. And then sometimes again, patients, bring that up and then find who they want to talk to. Interestingly, in this field now, there's more telehealth options for women in perimenopause and menopause to talk through their symptoms. I think because again, we had a dearth of medical providers. Really, we're siloed more in internal medicine and gynecology, and these organizations are trying to sort of target women who might have these direct questions. So I would say, again, finding someone through the Menopause Society website is important, asking your gynecologist or internist if they have this knowledge. And if they don't, then finding someone that does if you are having questions that cannot be answered. And I think that is what I hear often. They're finding patients and women are finding their way. And I think, again, discussions like today and really a lot of the educational efforts that are coming out of the Menopause Society and et cetera are really trying to expand, how we reach women and also how we discuss treatments and how we answer the questions that they have, right? Meet them where they are rather than say, oh, you're not in menopause yet. See you when you are. There's a lot of things that happen before menopause that we need to address.
Yeah. And I don't know if this is a great question, but I'm going to ask it anyhow. So throughout the ages, we're living longer. Was menopause at some point at the age of 31? Now it's 51. In the future, is it going to be 61, 71?
Yeah, it's a good question. There's like some other, some thoughts about that. As far as what I've seen in the, the literature, I mean, I think women are, again, living longer. The average lifespan of women now is 81.3 years. I don't think the age menopause has changed. I mean, we haven't, when we look at like the sort of census data or, sort of retrospect, I have not seen that has changed. You do hear like some changes in terms of what's happening with like menarche or puberty. Maybe that is inching, earlier. We do know some women who undergo earlier menopause can be, if you're a thinner, a smoker, women who have family history of earlier menopause. Sometimes those things can also trigger an earlier menopause, autoimmune conditions. And so again, if those are you could start to be having these symptoms, and it's not just, normal, right? We have to think about what are the symptoms, what does your menstrual cycle look like, what contraceptives have you been on, what's your, reproductive health history before we make a good assessment and then find something that'll work for symptoms, or that we say, okay, things look like they're progressing. You let us know, here's what we would recommend for this stage. And then, here's what we would recommend for this stage based on, again, who your sort of makeup.
When someone comes to you for the first time, do you have a list of questions in order and talk through that process? And because I think that might be helpful for a lot of women, especially, and men also, when they go to talk to their doctor, it's sometimes you're so ignorant that you don't even know the right questions to ask.
Mm-hmm. Well, so yes, I mean, I try and be very comprehensive, and I'm very lucky that I have my own practice, Bone and Body Women's Health, where I can have I now have a lot of time to spend with my patients, and so my plan is, yes, I mean, I honestly do what we've sort of been talking about, talk through, particularly, again, I see a lot of women with fractures and bone loss, so I ask them about all their fractures, including, stress fractures. I ask about a family history of osteoporosis, first menstrual cycles, what that looked like, what their childhood activity looked like in calcium, pregnancies, lactation, their alcohol, smoking history, activity level, falls, dizziness, balance, all of those things that are important really in the bone health. Any secondary osteoporosis, which is really a medical term for anything that could contribute to bone loss. So like we mentioned, some of those high level medications or surgeries, like things like gastric surgeries that might impact absorption of things like calcium and vitamin D, medications, even things like proton pump inhibitors, any rheumatologic condition.
It's really
a long time. It takes me a long time.
Yeah, it does.
And I look at all the labs, and we look at the DEXAs. A lot of times women are coming to me with many DEXAs to look at, and so I look through those and really mammograms. All those things are very important, and really, again, understanding like what is the midlife women's health picture. I see again with the focus on again, we don't talk about osteoporosis and prevention of bone loss. So a lot of women will come to see me with osteopenia or osteoporosis, and they didn't even know at the time of menopause. So that is, again, a workup that we do to make sure that there's no underlying causes, and we can do that very easily with some, blood tests and urine tests, and then really talk about individualizing the treatment options, which are many.
Yeah. In the age of technology, are you taking patients from different states? Like I'm out here in Oregon.
Yeah.
So if I called you up, can you take me on as a patient? And I don't mean me personally, but I mean, anybody that that is living in another state and they've been listening to this interview and this conversation that you and I are having, and they go, "Wow, this is pretty incredible," and I'd like to begin this process.
I'm actually outside of Chicago, but that's where my practice is located, up in Winnetka, Illinois, outside of Chicago. I do see some patients for virtual visits. That is an option. I have, there's so many interesting things about prescribing outside of your area. I usually say if you'd like to see me, I'm happy to talk to you, and then sometimes I can connect you with some other, folks across the country too.
Sure, make referrals in the various states.
Yeah, I've got there's a great group of a lot of bone clinicians that are really care a lot about their patients and how to make sure that they get the right treatment. So again, I think you have my resources, and you could probably share those if you wanted.
Yeah. What is your website? Because I know our listening audience would appreciate that.
It's my website is it's bone BONEANDBODYWH.com.
All
So
right.
boneandbodywh.com.
All right, which the WH is women's health, so
You bet.
bone and body women's health.
Yeah, I only see women. Yes, thank you. Yeah, thank you.
Yeah, except for you're seeing me today.
Except for I'm seeing you today.
Yeah,
I live
and
with
I appreciate
boys and
that.
men.
Yeah. Well, and you've exposed all my ignorance, and so, but it's when you're living with, people that you love, my mom and my wife and my sister, and then all the other people that are around my sphere. I mean, it affects men as well, and and like you said, I think sometimes I wonder, if I'm going through menopause. I think there's some things that are going on in my body that are changing, and I'm going, wait a minute, that's not possible.
No, I know there's always these questions about this andropause, but I mean, I don't think it's as dramatic as women's menopause, but there are right. Each sex has their specific changes. So.
Yeah, absolutely. All right. Well, is there anything else that you would like to leave with us? Any thoughts that we haven't covered? There's actually a few things that I wanted to touch on was muscle decline, skin elasticity, but I don't know if that's appropriate for another interview.
Yeah, maybe we'll do it. Yeah, maybe, because I know I always say, like, every discussion could be an hour in themselves. That's why my visits tend to everyone. I have questions for them, and women always have lots of questions for me. So, I just think this has been hopefully informative. I think it's so important that, again, we think about bone health and changes that are happening at menopause, along with the things that we talk about, like weight and vasomotor symptoms and vaginal dryness, because we have treatments for all of them, whether people want to know about those, and hormones and non-hormonal options, and we have treatments to offset bone loss and prevent and treat osteoporosis. So I think, again, this effort, a lot of efforts, with the companies we're working with to try and make a difference in how women feel and experience menopause is really it's really important, because again, like you said, education and appropriate knowledge and from trained professionals is really important to sort of help the masses.
Yeah, and just one last thought, one last comment that I'd like you to comment on. You had written that osteoporosis is a chronic disease that shouldn't be accepted as the normal part of aging. Explain that for our listening audience.
So I think that is a great recap. I mean, again, when we think about aging, and we think about, maybe some people sort of conjure up images of, like, women in wheelchairs or have poor posture. again, or having, fractures or potential living in assisted living. I mean, some of this is aging, and we're working through each thing individually, but we do not need to accept that, osteoporosis, starting even our 50s and 60s, is something that we need to live with. That we can prevent and treat fractures. We know what we talked about in the beginning, trying to age, gracefully with strength, posture, balance, and fracture free is possible. Primarily, again, if we think about making the appropriate screening first, making the appropriate diagnosis, and then treating if we have bone loss, whether that is mild to moderate, like osteopenia or low bone mass, or more advanced, like osteoporosis.
Yeah, well said. And we are against the end of our conversation, and I just want to say thank you. I mean, you've enlightened me, you've educated me on a lot of things that I had questions about, and so that if no one else got anything out of this, at least I did.
Yeah, well, good. I hope you can bring some back to your wife, and also, to the wider audience that you're impacting. So I thank you for your time.
Well, we have about 200,000 followers out there, so I'm assuming that there's a few out there that are going to be gleaning some of the nuggets of your wisdom and your knowledge. So I want to say thank you so much for being on Aging Today.
Thank you.
All right. This is Mark Turnbull, your host, and I want to thank all of you for tuning in to Aging Today. And we are the podcast where together we're exploring the many options to aging on your terms. Join us every Monday when we release a new conversation on Aging Today to your favorite podcast channel. And remember, we're all in the process of aging. And as we age, we really are better together. So stay young at heart.
You make me feel so young. You make me feel like spring has sprung. And every time I see your face, I'm such a happy individual. The moment that you speak, I want to go play hide and seek. I want to go and bounce the moon just like a toy balloon. Well, you and I are just like a couple of tots running across the meadow, picking up lots of forget-me-nots. So you made me feel so young. You made me feel there are songs to be sung, bells to be rung, and a wonderful fling to be flung. And even when I'm old and gray.
You've been listening to Aging Today, where together we explore the options to aging on your terms. Join Mark and his guest next week for another lively discussion on proactively aging on your terms, connecting you to the professional advice of his special guests, with the goal of creating better days throughout the aging process. Your host has been Mark Turnbull. Join Mark and his guests every week on Aging Today, your podcast to exploring your options for aging on your terms.
And even when I'm old and gray, you make me feel the way I feel today, 'cause you make me feel so. You make me feel so. You make me feel so young. So young. You make me feel so young. You make me feel so young.